Quick review on the use of the King airway. This happens to be the LT-SD, which is the version with the gastric access port, but the insertion and inflation, from a ventilatory standpoint, it's identical to the LT-D. Kind of three things to remember. The first challenge may be in getting the tube around the corner, the tip around the corner in the posterior pharynx. And because the tip is relatively straight, if you just try and go in, oftentimes the tongue falls back and wants to make the tip not want to go around the corner and go into the esophagus. So there's a couple of things, managing the tongue with your thumb or a tongue depressor or a standard laryngoscope blade, or actually even coming in from the side and then rotating the tip into position. But at any rate, the key is to get that tip around the corner and advance towards the esophagus. The second challenge is how do you make sure that the ventilatory openings are aligned appropriately with the airway inlet. We suggest, and this is the first step of this, to insert the product all the way. Because of the distensibility of the esophagus, this is typically possible, so you put the connector all the way to the teeth. Now that may be too deep in some individuals, but we suggest you start out in this position. Next, and we'll touch on the third element, and that's cuff inflation. To inflate both cuffs with a single line, it's going to take 60 to 70 cc's, a little more in big patients, a little less in small patients. Both the distal cuff and the proximal cuff are inflated with one balloon. And I point this out because if you are only using 20 or 30 cc's, which might be appropriate for an LMA, it's not going to be good enough for the King airway. Next, as you try and see if you've got an airway or not, in this case you can see I do. But if I didn't, because the tube was too deep, I would merely back this up until I actually got a good airway, and that way I know that those ventilatory openings are appropriately aligned with the ventilatory inlet. At this point, you can make sure that the cuff inflation volume is matched to this particular patient by either using a pressure gauge or by inflating or deflating with the cuff until you get a just leak condition at the ventilatory pressure you're employing, and then just give a little bit more so that you make sure you have a seal. Now, one of the things I like to demonstrate with this device is you can actually hook up to the pressure port of this pediatric resuscitator bag, and with the cuff pressure gauge, illustrate that you can actually get extremely high ventilatory pressures. This is a fundamental feature associated with all the King airways, that you get an extremely good ventilatory seal. And this is a reflection of the seal in the esophagus, so it prevents air from getting into the stomach, and also prevents air from coming out the mouth past the proximal cuff. So those two cuffs are above and below the opening of the airway and sealing it off. And for further safety, you can actually use the gastric access port to put up to an 18-French gastric tube down into the stomach and evacuate the stomach contents. The gastric access port is on the back side, and so this illustrates how you're capturing on the fact that you're already in the esophagus with the tip here. Now the airway openings are here trapped between the cuffs. So this seals in the oropharynx above the airway opening. This seals in the upper esophagus, and so you prevent air from going into the stomach and you prevent air from coming out the mouth. And as further safety, you can decompress the stomach so that none of the stomach contents are likely to come up and cause a problem.